Chapter 22, Immunologic Emergencies. Your national competencies, again, is medicine applies to the fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely ill patient. I don't feel as bad now. I feel like Nemo saying an anemone, an anemone. And if you ever pause to say it, you're just done. Like you just can't. We're done with it. Okay. Recognition and management of shock and difficulty relating to anaphylactic reactions. It's going to be the AMP, pathophysiology, assessment and management of hypersensitivity disorders and or emergencies. And this is allergic and anaphylactic reactions. All right, at least 1,500 Americans die annually owing to acute allergic reactions. Be aware of the possibility of acute airway obstruction and cardiovascular collapse and be prepared. Allergic reaction is an exaggerated immune response to any substance that may require epinephrine or anaphylaxis treatment. Anaphylaxis is the extreme systemic form of an allergic reaction involving two or more body systems. You must be able to distinguish between the body's usual response to an allergen and an allergic reaction. Ability to recognize and manage the symptoms of allergic reactions may be the only thing standing between life and imminent death for a patient. Anatomy review. The immune system protects the human body from substances and organisms that are considered foreign to the body. Without the immune system, a body would be under constant attack from any bacterium, virus, or other invader that wanted to make our bodies their home. Body protection systems are cellular immunity. The body produces specialized white blood cells called T cells that attack and destroy invaders. Humoral immunity is B cell lymphocytes produce antibodies that dissolve in the plasma and lymph to wage war on invading organisms. Cells producing immunity factors intercept foreign invaders as they enter the body. Given the right person in the right circumstances, almost any substance can trigger the body's immune system and cause an allergic reaction. Animal bites, food, latex gloves, and even semen can all be allergens. 5 general categories of allergens are insect bites and stings. When an insect bites a person and injects the bite with venom, it is called envenomation or a sting. Medications. The reaction of injected medication may be immediate and severe. Reactions to oral medications may be slower but can also be severe. Plants. People who inhale dust, pollen, mold, mildew, or other organic materials to which they are sensitive may experience an allergic reaction. Foods. Consuming certain foods, such as shellfish and peanuts, may result in a relatively slow, more than 30 minutes, reaction that may still be quite severe. Chemicals. Certain chemicals, makeup, soap, hair dye, latex, and other substances can cause severe reactions. Allergens usually are harmless. Antibody is a protein produced by the body in response to an antigen. Table 22.1 lists the common antibodies, their actions, and locations. Foreign substances invade the body through the skin, the respiratory tract, and the GI tract. Invasion through the skin may come in the form of injection. Invading substance pierces the skin and deposits foreign material into the skin. Absorption is the foreign material is deposited on the skin and slowly absorbed through the skin. Invasion by allergens may enter the respiratory tract as the patient breathes. The final way allergens attack the body is through the gastrointestinal tract via ingestion. Physiology review. When a foreign substance invades the body goes on alert and initiates a series of responses. First encounter begins the primary response. It mainly involves white blood cells. Macrophages greet, conform, and engulf invaders. Determine if they are allowed in the body. If the body is unable to identify an invader, immune cells are used to record the features of the substance. The immune cells design proteins that match each substance. The antibodies match up with the antigen and inactivate it. The body develops sensitivity through the primary response, which is the ability to recognize the foreigner next time it is encountered. The body places specific antibodies on basophils, which are stationed in specific sites within tissues, mast cells, which are on patrol through connective tissues, bronchi, GI mucosa, and other vulnerable border areas. I'm touching buttons here. Sorry, y'all, gotta get back to where I was. Chemical mediators are chemical weapons produced by basophils and mast cells. They contain granules filled with powerful substances to fight invading forces of antigens. Granules get ejected from mast cells and detonated if an antigen invades the body and combines with one of the antibodies. Degranulation, the granules burst, releasing powerful content. Launch and maintain the immune response. They summon more white blood cells to battle the invaders, and they increase blood flow to the area under attack. This is useful when a small invasion occurs to a limited area. It is dangerous when they spread throughout the whole body. When chemical mediators cause systemic effects, they cause anaphylactic reactions. So basically, you got a whole little war going on inside your body. This figure shows the sequence of events in anaphylaxis. First, the antigen is introduced into the body. Then the antigen-antibody reaction occurs at the surface of the mast cell. Then the mast cell chemical mediators are released, and the specific antibody reacts with its corresponding antigen. Then chemical mediators exert their effects on end organs. Vaccine produces immunity against disease. The body develops antibodies in response to the vaccine. It produces an immune response to neutralize the invading disease, develops antibodies in a controlled way. If actual virus enters the body afterwards, the virus is identified, antibodies are produced to kill it, and secondary response is an intense response to an invading virus. Acquired immunity is administration of a vaccine allows the body to produce antibodies without having to experience the disease. Immunized person remains unaware of the battle raging inside his or her body. Natural immunity is the body experiences the full immune response with all the effects of the disease. Vaccines, we just did that. No, no. Vaccines produce immunity against disease. The body develops antibodies in response to the vaccine. It produces an immune response to neutralize the invading disease, develops antibodies in a controlled way. If the actual virus enters the body afterwards, the virus is identified, antibodies are produced to kill it, and the secondary response is an intense response to an invading virus. We did just do all that. Okay. Skip to pathophysiology. An ever watchful and responsive immune system is essential to life and health. The immune system becomes hypersensitive to one or more substances during abnormal reactions. An allergic reaction is a reaction by the body's immune system that occurs when a person has been previously exposed or sensitized to a substance or allergen. Allergic reactions versus anaphylaxis. In an allergic reaction, this is mild or localized reaction. The body limits response to a specific area after being exposed to a foreign substance. A systemic reaction occurs throughout the body. Hypersensitivity occurs when a person reacts with exaggerated or inappropriate allergic symptoms after coming into contact with a substance perceived by the body to be harmful. Anaphylactic events should not be mistaken for heart attacks, heat stroke, or other conditions. Diseases related to allergies, such as allergic rhinitis, what is that?
Sinus infection.
Okay. Asthma and atopic dermatitis increase the potential for anaphylactic reactions. Anaphylaxis is a response mediated by IgG antibodies. Anaphylactoid reaction is a response that does not involve IgG antibody mediation. An anaphylactoid event may occur without the patient being previously exposed to the offending agent. Pathophysiologic response. When an invading substance enters the body, mast cells recognize it as potentially harmful and begin releasing chemical mediators. Two types of chemical mediators are histamine, causes the blood vessels in the local area to dilate and the capillaries to leak, and leukotrienes are more powerful than histamines. They cause additional dilation and leaking. White blood cells are called to the area to help engulf and destroy the enemy. Platelets begin to collect and clump together or aggregate. In most cases, this overreaction to harmless invaders is restricted to the local area being invaded. Anaphylaxis. Chemical mediators are released and the effect involves more than one system throughout the body as listed in Table 22.3. Initial effect may be seen from release of histamines with secondary effects following a few hours later. Histamine release causes immediate vasodilation, often presenting as flushed skin and hypotension, increased vascular permeability, resulting in angioedema. Edema can present as urticaria, airway constriction, and increased fluids in the airway. Smooth muscle contraction, especially in the respiratory and GI systems. This results in laryngospasm, bronchospasm, and abdominal cramping. Decreases the contractility or inotropic effects of the heart. When this effect is coupled with vasodilation, a person may experience profound hypotension. Later relief of leukotriene compounds the effects of histamines, further compromising with the respiratory status, causes coronary vasoconstriction, which worsens cardiac condition and myocardial irritability, and further contributing to the state of hypoperfusion. The remaining chemical mediators continue to worsen the situation. As a result, when the body undergoes an anaphylactic reaction, a person may not survive without immediate intervention. Clinical symptoms of anaphylaxis. The skin symptoms are often the first indications of anaphylaxis. A person may feel warm and flushed. Pruritus, that's hard to say. Itching is another early sign, which is due to vasodilation and capillary leaking. Area around the eyes is susceptible to this effect. Angioedema may contribute to airway compromise. Swelling of the hands and feet. Histamine is responsible for the urticaria experienced by the patient with anaphylaxis. Respiratory symptoms are the most common complaints: shortness of breath, dyspnea, tightness in the throat and chest, stridor, and/or hoarseness. This is often due to upper airway swelling in the laryngeal and epiglottic areas. Affected patients may complain of a lump in the throat. The lower airway is often involved as well. Bronchoconstriction and increased airway secretions may result in wheezes and crackles. Coughing or sneezing are common. Symptoms may be slow or rapid, less than 3 minutes available to halt this life-threatening process. Cardiovascular symptoms are serious complications of anaphylaxis. A decrease in cardiac output is complicated by vasodilation and increased capillary permeability. Decreased cardiac output and perfusion, increased ischemia, and potential for cardiac dysrhythmias. In this situation, tachycardia, flushed skin, and hypotension are synonymous with anaphylactic shock. Blood volume moving from the intravascular space to the extravascular space can cause shock. The body will not tolerate an acute blood loss of greater than 20% of blood volume. It includes a significant change in vital signs. increased heart and respiratory rate, decreased blood pressure. Gastrointestinal symptoms may occur, particularly when the antigen is ingested. Abdominal cramping is common. Nausea, bloating, vomiting, abdominal distension, and profuse watery diarrhea may also be present. The central nervous system symptoms: headache, dizziness, confusion, and anxiety, a sense of impending doom. These patients require rapid assessment and treatment. Anaphylaxis may affect two or more body systems. Table 22.4 summarizes the signs and symptoms of anaphylaxis compared with those of an allergic reaction. Patient assessment. This is highly challenging. Simultaneous assessment, problem identification, and intervening within seconds of arrival is crucial. Suspicion for anaphylaxis must be high if any of the pertinent symptoms are present. Response to antigens may occur in a multi-step manner with an immediate acute response being followed later by a delayed response. Reactions can be acute or delayed. Acute reactions have a rapid onset and typically result in the most life-threatening situation. Delayed reactions may take hours or longer to manifest, and the response is not usually as exaggerated. In prolonged persistent reactions, anaphylaxis symptoms continue over time from 5 to 72 hours. In a biphasic response, the patient experiences an initial reaction, appears to recover, and then experiences a recurrence of symptoms. Patients who experience an allergic reaction should be encouraged to seek medical attention to minimize the effects of a delayed reaction. Your scene size up, ensure the scene is safe. Patient's environment or recent activity may indicate the source of the reaction. A respiratory problem reported by dispatch may be an allergic reaction. Never enter a scene where more than one person is experiencing the same symptoms with a similar onset. Consider the need for additional or specialized resources and call for those resources earlier rather than later. Do not neglect the possibility that traumatic injury may also be present secondary to the medical emergency. Determine the mechanism of injury or nature of illness, and do not let your guard down. Primary survey. The severity of the problem will be indicated by the patient's presentation. Immediately begin airway evaluation and management in case of any change in mental status in an anaphylactic patient. Respiratory symptoms should be swiftly assessed. A noisy upper airway may be an early sign of impending airway occlusion. Assess breath sounds for wheezing. Breath sounds may diminish as the patient's condition becomes worse. Stridor is a harsh and high-pitched sound heard on inspiration. Occurs when swelling in the upper airway begins to close off the airway. It can eventually lead to total obstruction. Position an alert patient in a tripod position leaning forward. Feel free to initiate high-flow oxygen therapy. For unresponsive patients or those with an altered mental status who are in severe respiratory distress, assist ventilations using a bag mask device attached to a high concentration of oxygen. Palpate for the presence and quality of a radial pulse to quickly identify how the patient's circulatory system is responding to the reaction. Begin basic life support measures if a patient is unresponsive or pulseless. Assessments for rapid pulse rate, pale, cool, cyanotic, or red, moist skin, and delayed capillary refill may indicate hypoperfusion. Treatment for shock includes administering oxygen, placing the patient supine, preventing the loss of body heat. Definitive treatment for shock resulting from anaphylaxis is epinephrine. Expose and evaluate the skin for erythema, rashes, edema, moisture, pruritus, and urticaria. Immediate transportation along with patient's medication to an appropriate facility is required if anaphylaxis is suspected. Assessment skills to be used to identify the potential for anaphylaxis, take aggressive action to treat the patient, and stop the anaphylactic process. If the patient has signs of respiratory distress or shock, treat those conditions and transport. Continue the assessment at scene if the patient is calm and does not exhibit any symptoms. Your history taking. Investigate the chief complaint and history of the illness. Identify associated signs and symptoms. If the patient is responsive, begin by obtaining the sample history. Check if any interventions have already been completed. Check if the patient has experienced a severe allergic reaction in the past. Be alert for any statements regarding previous exposure to common antigens. Secondary assessment, perform a physical examination. If the patient is exhibiting life-threatening signs and symptoms, perform the examination en route to the hospital. Auscultate for abnormal breath sounds. Carefully inspect the skin for the source of the reaction. Rapidly spreading rash can be concerning because it may indicate a systemic reaction. Red hot skin is typical in the early stages, suggesting a systemic reaction. Systemic reaction alters mental status. And vital signs, these help determine whether the body is compensating for stress. Assess baseline vital signs, including pulse, respirations, blood pressure, skin, pupils, and oxygen saturation. Rapid respiratory and pulse rates may indicate respiratory distress or systemic shock. Tachycardia and hypotension indicate systemic vascular collapse and shock. Skin signs may be unreliable indicators of hypoperfusion. Monitoring devices, use tools such as a cardiac monitor. Dysrhythmias may be associated with anaphylaxis. Monitoring by pulse oximetry may alert you to low oxygen saturation, which will assist in identifying the degree of respiratory distress. Factors such as decreased circulation and exposure to carbon monoxide can alter pulse oximetry readings. End-tidal carbon dioxide levels are more reliable than pulse oximetry in low perfusion states. For non-intubated patients, the waveform is more important than the numeric value obtained during capnography. The decision to administer oxygen to a patient experiencing an allergic reaction should be based on a careful assessment of the patient's airway and breathing and not solely on the pulse oximetry readings. Reassessment in general, reassessment is conducted typically en route to the receiving hospital. Special attention should be given to any signs of airway compromise. Deterioration can be rapid and fatal. Special attention should be given to any signs of airway compromise. Monitor the patient's anxiety and mental levels. Watch for signs of shock and treat immediately. Identify the severity of the reaction. Mild reactions may only require supportive care and monitoring. Anaphylaxis requires more aggressive treatment. Interventions: check the effects of epinephrine administration. Check if the patient's condition has improved or if a second dose is required. Recheck interventions, consult with medical control, identify and treat changes in the patient's condition. Communication and documentation. When to contact medical control depends on your assessment findings and the urgency of care required. In some allergic reactions, you may use standing orders to administer epinephrine. For less severe reactions, medical control can advise about the use of epinephrine. Medical control is most helpful in this situation. Documentation should include signs and symptoms and explain why you chose to provide the care you did. Ensure to record the patient's response to the treatment. Emergency medical care is essential to differentiate between anaphylaxis and other conditions with similar symptoms. People with allergic reactions are separated into two groups for treatment purposes. The first group includes patients who have signs of an allergic reaction but no signs of anaphylaxis. The second group, which includes patients with signs of anaphylaxis, require 100% oxygen, epinephrine, and antihistamines. Whenever dyspnea and/or signs of shock are present with signs of an allergic reaction, you should administer epinephrine, closely monitor the patient, and provide rapid transport. For patients who appear to be having a severe allergic reaction, administer basic life support, provide prompt transport to the hospital, remove the patient from the situation involving the antigen or the antigen from the patient, maintain the airway, use an appropriate oxygen delivery device for supplemental oxygen administration, and consider early transport. Administer high-flow oxygen via a non-rebreathing mask at 15 liters per minute if the patient is breathing inadequately, and be prepared to assist ventilations. Maintain a high index of suspicion for the potential for airway occlusion because of swelling or edema. If necessary, treat the patient for shock by placing him or her in the position dictated by local protocol. Maintain body heat with a blanket and initiate IV therapy. Maintain circulation by administering isotonic solution at a wide open rate. It is crucial to initiate 2 IV lines en route to the emergency department if the patient does not respond to epinephrine. If there is no response from the patient, consider calling for paramedic backup for administration of a vasopressor in conjunction with fluid administration. Find out which interventions have been completed before your arrival. Inform medical control of the patient's condition. Administering epinephrine. Early administration of epinephrine should be a priority. Use the IM route if the patient shows evidence of airway or respiratory compromise or hypotension. Administration in the thigh is preferred over the deltoid site for more rapid absorption. Where is the deltoid?
Shoulder.
Very good.
Upper arm.
Yes, thank you. Subcutaneous administration of epinephrine is unpredictable and may have delayed effects in the presence of shock. Epinephrine can rapidly reverse the histamine-related effects of anaphylaxis. Many patients and EMTs carry epinephrine in the form of an EpiPen. Patients who receive epinephrine must be monitored closely for adverse effects. Direct order for medical control required to use or help a patient use the auto-injector. Follow steps in skill drill 22.1 to use an EpiPen auto-injector. In a life-threatening situation, do not delay administration of epinephrine to expose the thigh. An EpiPen can be administered directly through clothing. Injection time is 3 seconds. Take steps to ensure the patient's leg does not move during administration. Properly dispose of the injector after administration in a biohazard container. It is required to give more than 1 injection of epinephrine if the patient displays decreased mental status, increased breathing difficulty, or decreased blood pressure. Be sure to consult medical control first. Other allergy kits may contain oral or IM antihistamines and are comparatively slower. Epinephrine and antihistamines work synergistically. Epinephrine may cause the patient's blood pressure to increase significantly. Side effects of epinephrine are tachycardia, anxiety, pallor, dizziness, chest pain, headache, nausea, vomiting. These side effects are worth the trade-off when epinephrine is used in a life-threatening situation. However, patients who do not exhibit signs of respiratory compromise or hypotension, and do not meet the criteria for a diagnosis of anaphylaxis should not be given epinephrine. Provide prompt transport for any patient who is experiencing an allergic reaction or who has experienced poisonous envenomation or bites. Continue to reassess the patient's vital signs en route. If the patient's condition improves, provide supportive care, including continuing oxygen therapy during transport. Consider early transportation if the patient needs resources beyond your capabilities. Even if you are able to stop the reaction and the patient begins to recover, it is recommended that patients be observed in a medical facility. As many as 20% of patients have a recurrence of symptoms within 8 hours, even if they have been symptom-free for a time. Table 22.5 summarizes the management of anaphylaxis. Assessment and management of insect stings. Insect stings allergies accounts for approximately 90 to 100 deaths each year in the United States. The stinging organ of most bees, wasps, and hornets is a small hollow spine projecting from the abdomen. Some ants, especially the fire ant, strike repeatedly, injecting a particularly irritating toxin or poison at the bite sites. Signs and symptoms of insect stings and bites include sudden pain, swelling, localized heat, widespread urticaria, and redness in light-skinned people, usually at the site of injury. There may be itching and sometimes a wheal, which is a raised, swollen, well-defined area of the skin. Applying ice sometimes makes wheals less irritating. Attempt to remove the stinger by scraping the skin with the edge of a sharp, stiff object such as a credit card. Do not use tweezers or forceps. Squeezing may cause the stinger to inject more venom into the wound. Once the stinger is removed, wash the area with soap and water or a mild antiseptic. Try to remove jewelry from the area before swelling begins. Position the injection site slightly below the level of the heart and apply ice or cold packs to the area. Be alert for signs of airway swelling and other signs of anaphylaxis. Place the patient in the supine position if indicated and give oxygen as needed. Monitor the patient's vital signs and be prepared to provide additional support as needed. The best management of anaphylaxis and allergic reactions is to educate patients about prevention and self-preservation. Avoid the antigen, notify all health personnel of the allergy, wear identification tags or bracelets, carry an anaphylaxis kit or EpiPen, and report symptoms early. All right, y'all, that's it for that one. It's been a long night, a lot of information. Does anybody have any questions?
No, ma'am.
All right, so these lectures will be uploaded tonight, so that you can review them, re-listen to them. If you do have any questions, contact an instructor. Tomorrow's class should be mirrored. It's going to be the same chapters, but I will be at work, so that's going to be doodle. And then I will see y'all again Wednesday.
Alrighty.